This is a presentation on attention deficit hyperactivity disorder. This presentation was created by 2 Nebraska Methodist College students in the Doctor of Nursing Practice program. The purpose of this presentation is to increase provider awareness of ADHD across disciplines. ADHD is very common, but is often underdiagnosed and undertreated, which can lead to adverse consequences. We will discuss the importance of ADHD treatment, the etiology and pathophysiology of this disorder, symptoms, treatment, both pharmacological and non-pharmacological, as well as implications for practice. We hope that the review of this disorder will increase your awareness of ADHD, as well as improve your ability to diagnose and either treat or refer children needing treatment. We have several learning objectives for this course. This educational presentation is designed to help healthcare providers to become more familiar and comfortable with ADHD in the pediatric population. We will discuss the etiology, pathophysiology, and presentation of ADHD, as well as diagnosis and treatment options. By completion of the program, learners will be able to 1. Verbalize understanding of the pathophysiology of pediatric ADHD, 2. Use diagnostic tools to correctly identify pediatric patients with ADHD, and 3. Correctly verbalize appropriate treatment options for pediatric patients with ADHD. These are the learning outcomes. Let's look at why ADHD is significant. When left untreated, ADHD can lead to poorer health outcomes. Adolescents with ADHD have higher rates of motor vehicle crashes, substance abuse, and school dropout. Patients with untreated ADHD do not perform as well academically as their medicated counterparts. The symptoms also affect the social life of affected patients, making it difficult to function. Long-term issues include tension with peers, decreased intimate relationships, and an increased rate of family conflict. Furthermore, effects of untreated symptoms can greatly impact patients even into adulthood, as their work productivity suffers and job instability develops. ADHD seems to increase sick days used, decrease work quality, and reduce productivity. This may lead to financial instability. Additionally, ADHD increases the chances that an individual will develop other comorbid psychiatric conditions. Because one of the major consequences of failure to diagnose ADHD in the office is lack of treatment, providers must be vigilant in assessing and identifying this potentially limiting disorder and treating it. There is a significant gap between current provider knowledge and treatment competence and recommended capacity regarding pediatric ADHD. Let's take a look at the facts here. Nearly 1/10 of children in the United States and worldwide, this is both the US and worldwide, have received a diagnosis of ADHD at some point in their lives. The stunningly high rate means we as providers need to be aware and vigilant in our clinics so that our patients can be diagnosed and treated. Unfortunately, 23% of kids with the diagnosis of ADHD receive neither behavioral nor pharmaceutical treatment. Alternately, we are managing to start 62% of the kids on medications and 46.7% on behavioral treatment. We know that there is room for improvement in the provider's offices in the diagnosis and treatment of ADHD. A quarter of pediatricians do not screen for ADHD in their routine visits. This number should be closer to 100%, and that's part of the reason for this program, to increase awareness. Furthermore, a quarter of all providers never treated or co-managed patients with ADHD. The gap in knowledge and capacity is evident. As discussed in the learning objectives, this program is designed to increase awareness of ADHD presentation and pathophysiology, as well as improve providers' ability to screen for and treat children with this disorder. So let's take a look at what ADHD is. The etiology and pathophysiology of ADHD is not well understood, but we do know that there are neurological factors that contribute to the development of this disorder. Deficits in brain structure, neuronal functioning, and connectivity have been noted in these patients. Furthermore, genetics appear to play an important role. ADHD is 2 to 8 times more likely to occur in children with a first-degree relative with this disorder. And that can be something that you target in the office, asking if there are any other family members with the disorder. Genetics, we just talked about that, 2 to 8 times more likely with the first-degree relative. Maternal obesity before pregnancy, cigarette, alcohol, or drug use during pregnancy, environmental toxin exposure to the mother or to a young child. This can be something such as lead. That is one of the reasons that we do lead screenings in the pediatric office on a routine basis. Brain injury and low birth weight can also be contributing risk factors. Okay, now moving to diagnosis. And now on to the diagnosis of ADHD. Symptoms of ADHD in pediatrics include the following that are listed here: poor attention, impulsivity, hyperactivity, poor grades in school, behavioral outbursts at home or in social situations. These symptoms must inhibit appropriate functioning in daily life to be considered a diagnosis, though. We will look further into these symptoms in a minute. So, there are subtle differences between the presentation of ADHD in boys and girls. ADHD is more common in males, and that's according to the National Institute of Mental Health. Girls tend to express the inattentive subtypes more often, whereas boys are more likely to fall into the hyperactivity classification. Furthermore, girls are more likely to exhibit internalizing symptoms. These things include forgetfulness, wandering thoughts, and as we mentioned, the inattentive subtype. Whereas boys more often exhibit externalized symptoms, such as agitated behavior and restless energy, and as we mentioned, the hyperactivity classification. This leads to a higher rate of diagnosis among males. It is important to watch for this in the clinical setting so we do not miss the diagnosis among our female patients. Upon exam, physical assessment should include a thorough family history. The child should be assessed for physical functioning, including a thorough physical exam. Special attention should be given to possible genetic conditions, signs of abuse, possible substance abuse, or other mental health disorders. General observation in the office during the exam may also reveal some behavioral symptoms, but further assessment in other settings should be considered as well, especially if there's a suspicion for this disorder. The child should be screened for lead levels, thyroid dysfunction, and anemia as well. As far as observational assessments go, this should occur in 3 categories. School, which can be completed by teachers or school counselors. The family and home assessment can be completed by the parents. Social activities may include assessments completed by coaches. If children are old enough, they may also be able to complete a behavioral assessment for themselves, and that can help them feel included in the plan of care. There are several differentials to consider before arriving at the diagnosis of ADHD. We should be looking for lead poisoning, thyroid dysfunction, anemia, physical abuse, illicit substance abuse, anxiety, autism, mood disorders, sleep disorders, which may include obstructive sleep apnea or restless leg, fetal alcohol syndrome, hearing or vision loss, learning disorders, or even seizures. The American Psychiatric Association defines attention deficit hyperactivity disorder as a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning. The key words here are a persistent pattern, and it must interfere with functioning. Now, when we say persistent, we mean 6 or more symptoms for 6 or more months. This can't be a recent occurrence. This has to have occurred for at least half a year. So let's look at some of the symptoms of inattention. Keep in mind that the symptoms of inattention must be inappropriate for the developmental age of the child and must negatively interfere with functioning. So obviously the standards of attention would be different for a toddler than for an adolescent. But in general, here are some things to watch for. Children that fail to give attention to detail, they make careless mistakes in school. An example of this might be not reading the directions of an assignment and failing to complete the obvious requirements. Difficulty sustaining attention. This can be at school or at play. An example may be a child is unable to remain focused during sustained reading or during a long game. The child does not seem to listen when being spoken to. They may seem distracted even though no obvious distractions are present. The child does not follow through on instructions. An example of this may be failing to complete household chores correctly. Difficulty organizing tasks or activities. This can be manifest as disorganized belongings, messy work, or failing to meet deadlines. Dislikes or avoids tasks that required sustained attention. The child may avoid homework, lengthy reports, sustained readings, long chores at home because it is difficult to sustain attention. The child often loses things required for tasks or activities. This may include school supplies, glasses, wallets, other necessary items. The child is often distracted by extraneous stimuli. An example may be an unrelated thought that may distract an older child or a noise that may distract younger children. They are often forgetful in daily activities or tasks. This may include homework, chores, returning phone calls, or paying bills when they're older. Hyperactivity is displayed in multiple ways. The child may often fidget or tap their hands or feet. This is evident in children who can't seem to sit still. They're always on the go. Often leave seat in situations where they should be sitting. This is often noticed in school settings. The child often runs or climbs in inappropriate situations. In older children, this may be manifest or described as feeling restless, even if they're able to control the impulse. Unable to quietly engage in leisure activities. This is seen in kids who cannot seem to play quietly, but they're always restless and noisy in their play. Kids are on the go as if driven by a motor. An example is a child who is unable to sit still at a restaurant but squirms or leave their seats repeatedly. Kids with ADHD often talk excessively and sometimes talk over other people. They often blurt out answers before questions have been finished. Finishing sentences is another common manifestation of this. Kids have difficulty waiting their turn. This can be at school, in the classroom, or at play, such as on the playground. Interrupting or intruding on others is also a common manifestation. This may include butting into a game without being asked, or starting to play with the toys of another child. And you can see how this would inhibit proper functioning both in school and in social situations. Other diagnostic qualifications. The American Psychiatric Association further specifies that the symptoms must be present before the age of 12. Several of the symptoms must be present in 2 or more settings. This may include school, play, or social settings, home, or work. There is clear evidence that the symptoms interfere with social, academic, or occupational functioning. You may see grades decline or loss of friendships, loss of job. The symptoms cannot be explained by another physical or psychiatric disorder such as schizophrenia, intoxication, substance abuse, mood disorders, or personality disorders. According to the DSM criteria, there are several subcategories of ADHD. The combined presentation must have both inattentive and hyperactive impulsive criteria to met in the last 6 months. Predominantly inattentive must meet the criteria for inattention, but may lack the hyperactive impulsive component. This subtype is more often seen in girls. The predominantly hyperactive impulsive type may lack the inattentive component, but meets the criteria for hyperactive and impulsive. So there are some diagnostic tools we can use to identify ADHD. This is an algorithm that was developed by the American Association for Family Physicians, and it should be implemented in the primary care setting. So you can see here, a patient presents with inattention or hyperactivity. We evaluate for ADHD, and I will show you the screening tool that we will use in a moment. We either come to an ADHD diagnosis or do not. If another diagnosis is found, then we'll evaluate and treat as needed. If there is a confirmed diagnosis of ADHD, we are going to treat the coexisting condition and reevaluate if management is still needed. But if there's no coexisting condition, if there's no other explanation for the symptoms, then we will move to treatment. This may include education and behavioral management or medication management. We'll reevaluate if symptoms do not improve, but continue if they do. And management will be described in a moment as well. There are several that are free and several that can be purchased. It is best to determine what are available in your care setting. Children who are old enough to fill out the forms themselves should be allowed to participate in the screening. You'll also want parents and teachers, or possibly coaches, or other people that are frequently in contact with the individual to have the opportunity to fill out these forms as well. You can see that each of the forms is tailored to different age levels, so be aware of that, and each have different groups filling out the forms. So as an example, this is the Vanderbilt Children's Hospital parent rating scale. You can see some of the questions here, and they're similar on all of the tools. This is just the example that we have for you. And it's rated on a scale of 0 to 3, never or very often. Things like the child does not pay attention to details. They are making careless mistakes, such as in homework or employment. They're having difficulty sustaining attention. They're not listening. They're having trouble following through on instructions. They're difficult organizing tasks and activities. They're avoiding things that require sustained attention. You can see these are all some of the symptoms that we previously discussed. Fidgety, leaving their seat, running around, things like that. Now that we've talked about common manifestations of ADHD, let's look at what this disorder appears like in practice. ADHD often manifests in school-aged children, but may be seen in adults that were not diagnosed as children. These symptoms are present for more than 6 months in order for a diagnosis to be made. You may notice that the child is distracted by objects in the room or your assessment tools. They may squirm in the office, climb on the chairs and exam table, and just can't seem to sit still, as if they were driven by a motor. Alternatively, the child may be less distracted by things in the room and more distracted by their own thoughts. They may be off in their own world. The parents will note that the child acts like this at home and in school. A careful interview may reveal that grades are suffering due to symptoms, and teachers often approach parents about behavior that occurs in the classroom. This may include inability to sit at the desk, impulsive comments made without raising hand, careless mistakes made on homework, difficulty engaging in sustained activities such as reading or test taking. Older children may have a difficult time with punctuality and are often late to school or work. This can be problematic for adults who are trying to hold a job. ADHD patients lose things often, including keys, homework, glasses. They are intrusive and may disrupt other children's play without waiting for an invitation to join the game. This sometimes leads to poor social skills and few friends. Parents often note that the child does not follow through with chores at home and climbs and runs inappropriately when at a restaurant. They have a difficult time engaging in quiet play and so are often active and noisy. As you talk with the patient, you may notice they fail to allow you to finish sentences before they interrupt with answers. They may also be easily distracted and have a hard time staying on track when answering your questions. Their thoughts may wander. The parents should be instructed to fill out a diagnostic questionnaire, as well as taking one to the child's teacher at school. As you will recall, the symptoms must be present in more than one setting. Now on to treatment. Treatment for ADHD involves a multidimensional system which includes 1. Behavior therapy, including training for parents, 2. Medication management, and 3. School accommodations and interventions. There are many treatment options, so parents should work closely with everyone involved in the child's life: healthcare providers, therapists, teachers, coaches, and other family members. Taking advantage of all the resources available will help parents guide their children towards success. We will begin by discussing non-pharmacological treatment. Non-pharmacological interventions should become increasingly focused on the individual as patients mature and become agents of implementation in their care. Behavior therapy, given by parents, teaches children to better control their own behavior, leading to improved functioning at school, home, and in relationships. Learning and practicing behavior therapy requires time and effort, but has lasting benefits for the child. Parent-led behavior therapy aims to treat the core symptoms of ADHD and associated oppositional and non-compliant behavior. It combines behavior management techniques with novel therapeutic elements based on developmental models of social and cognitive development. So, why should parents try behavior therapy first before medication? Behavior therapy is an important first step because 1. Behavior therapy gives parents the skills and strategies to help their child. 2, behavior therapy has been shown to work as well as medication for ADHD in young children. And 3, young children have more side effects from ADHD medications than older children, and the long-term effects of ADHD medications on young children have not been well studied. Routine and tools include 1, checklists. These can be useful for anything from getting out of the house on time in the morning to doing homework after school to the bedtime routine. Since the steps necessary for completing a task often aren't obvious to kids with ADHD, defining them clearly ahead of time and posting them prominently makes a task less daunting and more achievable. 2, using a planner is essential for kids with ADHD who have what's called poor working memory, which means it is hard for them to remember things like homework assignments and chores. 3, a reward chart at home, as well as at school, can help motivate kids who are easily distracted and struggle to acquire new skills, which is common among ADHD patients. And 4, educational therapists also recommend assigning a time limit for each step, particularly if it is a bigger, longer-term project. Deadlines can sneak up on all of us, but kids with ADHD are particularly susceptible to underestimating how long it will take to do something. To bolster kids with ADHD, learning specialists teach a mix of specific interventional strategies. Listed in this table here is an outline of behavioral therapy for children and adolescents with ADHD. When combined, these interventions will help behavioral symptoms of ADHD in a variety of settings. Behavioral therapy aims to treat symptoms that occur in 3 areas of life: home, school, and social situations. Behavioral parent training helps parents to develop skills to use at home with their children. Expected outcomes include a child's improved compliance with parental commands, adequate parental understanding of behavioral principles, and parental satisfaction with treatment. Parents have more success with this type of treatment if they learn how to use timeout correctly, respond consistently to their child, interact positively with their child, and practice learn techniques with their child during program sessions. For behavioral modification in school, behavioral classroom management is the intervention of choice. This intervention provides teachers with behavioral therapy principles and self-regulation interventions for use in the classroom. Expected outcomes for this intervention includes improved student attention to instruction, compliance with classroom rules, decreased disruptive behavior, and improved work productivity. When behavioral classroom management is tailored to meet individual students' needs and delivered in a positively reinforcing environment, it is more effective. Minimal use of punishment strategies has also shown to improve outcomes. Finally, behavioral peer interventions are used for helping children to behave appropriately in social settings. This type of behavior therapy focuses on peer relationships. They are often group-based interventions provided weekly and include clinic-based social skills training used either alone or concurrently with parental training in behavioral management, medication, or both. This allows children to role-play appropriate behavior and learn what behavior is acceptable in social situations with peers. While this type of intervention produces minimal effects when used in isolation, it has shown positive effects on parental ratings of ADHD symptoms when used concurrently with clinic-based parental training in behavior management. Behavioral peer intervention programs that are effective should contain elements of parental training in behavioral management and behavioral classroom management. When used together, these 3 behavioral therapy interventions will help patients and parents to target problematic behaviors in a variety of settings. It is an appropriate place to start treatment of ADHD. Now, on to pharmacological therapy. Pharmacological interventions are recommended by clinical guidelines for ADHD as part of a comprehensive treatment program, including a behavioral therapy component, if there is insufficient response to non-pharmacological treatment. The decision about which medication should be used to treat ADHD depends on a range of factors, including presence of comorbidities, undesirable effects of the medication, individual compliance needs, potential for drug diversion, and the personal preference of patients and their caregivers. There's a lot to consider. Pharmacological and psychosocial treatments in the form of parent behavioral training and school behavioral interventions have empirical support for treatment of ADHD in children and adolescents, and they can be used either alone or in combination. Pharmacological treatment of ADHD has been found to be associated with improved academic achievement in elementary school children, improved health-related quality of life in children and adolescents, and improved brain function. The main classes of available ADHD pharmacological treatments include stimulants and non-stimulants. Stimulants are the best known and most widely used ADHD medications. Between 70 and 80% of children with ADHD have fewer ADHD symptoms when they take these fast-acting medications. Non-stimulants were approved for treating ADHD in 2003. Non-stimulants do not work as quickly as stimulants, but they can last up to 24 hours. Let's look a little bit closer at these treatments. Stimulants are approved by the Food and Drug Administration to treat ADHD in children and adolescents and are considered first-line pharmacological agents in the treatment of ADHD. Stimulants, which are composed of methylphenidate and amphetamines, increase levels of norepinephrine and dopamine by facilitating their release in the prefrontal cortex. Methylphenidate binds to the dopamine transporter and blocks the reuptake of dopamine from the synaptic cleft, whereas amphetamines increase the availability of norepinephrine and dopamine at the synaptic cleft by displacing them from the presynaptic terminal storage sites and by blocking the action of a degradative enzyme. Stimulants have over 50 years of history of clinical use in the treatment of ADHD and are the most commonly prescribed psychotropic medications in children. On this slide are some examples of these types of stimulants. Methylphenidate includes Ritalin, Concerta, Focalin, etc. Amphetamines include Adderall, Dexedrine, and others. Now, both methylphenidate and amphetamines are available in once or twice daily long-acting formulations and have empirical support for short-term efficacy and safety and long-term effectiveness and tolerability. Tables 1 and 2 show a listing of the available methylphenidate and amphetamine formulations. You can see the distinctions here between the short-acting and long-acting and the appropriate dosages. Amphetamines are listed on this slide. Now, the most common side effects of stimulant medications to consider include appetite loss, abdominal pain, headaches, and sleep disturbance. Watching children closely for these adverse effects is important. Loss of appetite can lead to growth restriction if the child becomes malnourished. Abdominal pain can further increase the chances of poor appetite. Sleep disturbance can occur, especially if the medication is taken too late in the day. So watching a child's growth and development as well as their vital signs at each visit is important. While stimulants are typically the first choice of medication used to treat attention deficit hyperactivity disorder, there are several non-stimulant medications that may be prescribed. Non-stimulants may be prescribed if the patient does not respond to stimulants, if side effects of stimulants are too great or too unpleasant, if the patient has a history of certain heart conditions that may be exacerbated by a stimulant, or if they have a history of drug abuse or bipolar disorder. Here is a table of commonly used non-stimulant medications. Strattera is the first non-stimulant medication that has been FDA approved for the treatment of ADHD in adults and children over the age of 6. Atomoxetine is the class of medication known as selective norepinephrine reuptake inhibitors. In addition to the above drugs, Catapress, also called clonidine, and Tanex, guanfacine, are sometimes used to help manage ADHD symptoms. Both of these medications were originally used to treat high blood pressure, but they have been found to be helpful in reducing hyperactivity and impulsive symptoms. They do not appear to be as effective in improving symptoms of inattention and are usually only used to treat ADHD when you can't tolerate or don't respond to Strattera or stimulants. Also remember that these medications can affect blood pressure and so should be monitored closely. Wellbutrin, bupropion, is a different type of antidepressant that has been found to reduce symptoms of ADHD and depression in many patients. As depression may be comorbid with ADHD, this may be an effective medication for patients that exhibit symptoms of both. Side effects of non-stimulants include stomach upset, tiredness or problems sleeping, and dizziness. Some of these side effects can be mitigated through medication timing. For example, if the medication is prone to causing sleepiness, it may be given at night. Non-stimulants may be helpful in children who cannot tolerate stimulant side effects. Stimulants can sometimes worsen anxiety symptoms, so occasionally atomoxetine or guanfacine may be started in children with comorbid anxiety disorders. Furthermore, when weight loss due to loss of appetite becomes a problem when children are on stimulants, they may be switched to a non-stimulant. In summary, ADHD is a common childhood condition. It affects 5 to 10% of children worldwide. Symptoms may include poor attention, impulsivity, hyperactivity, poor grades, inability to sit still, agitated behavior, wandering thoughts, and behavioral outbursts at home or in social situations. These symptoms must be inappropriate for the developmental age of the child to be classified as ADHD. In order to diagnose a child with ADHD, there must be a persistent pattern of inattention or hyperactivity, impulsivity, that interferes with functioning. These behaviors can manifest as inattention and or hyperactivity, impulsivity. At least 6 symptoms must be present for at least 6 months. Additionally, symptoms must be present in at least 2 settings. This may include school, work, play, home, social settings. So collaboration with parents, teachers, coaches, or other observers is a very important resource. Treatment should start with a non-pharmacological method, including behavior therapy. Pharmacological agents available include stimulants such as methylphenidate and amphetamines, or non-stimulants such as guanfacine and atomoxetine. There is definitely room for improvement in the assessment and management of ADHD. Recall that 24% of pediatricians did not screen their patients for ADHD, as reported in 2016, and 24.8% of all healthcare providers never treated, managed, or co-managed ADHD. Indeed, these rates show implications for practice changes. We would like to present 4 recommendations for all healthcare providers. Number 1, all providers should routinely screen for ADHD in their pediatric patients. Number 2, all providers complete an ADHD educational course, such as this, so they are comfortable in the assessment and management of this common condition. 3, collaboration with parents, schools, therapists, and the patients themselves should always occur with treatment. And 4, furthermore, referral to an ADHD specialist should occur if treatment is not effective or if the provider is not comfortable with management. These implications are aimed at improving the treatment of ADHD. All right, let's look at a couple of case studies. We have Alex, age 7. He and his mother present to your family practice office today. Alex's mother notes that he has had some concerning behavioral issues that she began to notice about 3 years ago. But they've gotten worse over time and more noticeable at school. His teachers note that he has trouble staying focused. He often gets out of his seat at inappropriate times. He blurts out answers to questions without raising his hand. He loses his pencils and pens, forgets to complete homework assignments, and becomes aggressive when asked to wait his turn on the playground at recess. At home, Alex's mother says he is always, quote, on the go, with very high energy. He is short-tempered with his younger sister, has difficulty staying focused when completing chores, and seems not to listen when being spoken to. These symptoms are impeding his functioning at home and school. You realize that more information and testing should be done for this child before you can diagnose him, but you suspect he may be exhibiting symptoms of ADHD combined presentation, ADHD predominantly inattentive presentation, ADHD predominantly hyperactive or impulsive presentation, or this child does not display characteristics of ADHD. I'll give you a moment to think about this. Okay, hopefully you noticed a couple of key words here. These symptoms started 3 years ago and they're impeding his function. So right there we know that if he is exhibiting these symptoms, he may be able to qualify for a diagnosis. We're looking at symptoms here and notice that he's having trouble staying focused. He gets out of his seat. He loses things. He's forgetting things. He's blurting out. He's aggressive. Difficulty staying focused. It's almost like he's not listening when being spoken to. These are symptoms of both inattention and hyperactive impulsive behavior. So we're going to need to have his mother and some employees at school fill out some of those diagnostic tests, but we're thinking he may have a combined presentation. This is Macy. She's 12. She and her mother present for a routine physical exam prior to her participation on a basketball team. During the visit, you notice that Macy talks very fast. She has difficulty focusing on the questions you're asking and often blurts answers before you even finish asking the question. You ask her mother if this is typical, and she reports that Macy has always been a very wired child with high energy. You ask how she does in school, and her mother reports that her grades are not great. You know you need more information in order to identify abnormal behavior for this child. You send a questionnaire to be completed by A, her teacher, B, her basketball coach, C, her parents, or D, all of the above? Again, with this scenario, I want you to pick out keywords here, and I'll give you a moment to think about it. All right. Hopefully you picked up on a few things here. Macy talks very fast. She has difficulty focusing. She's blurting things out. Her mother describes her as wired and high energy, and her grades are suffering. These are all warning signs. Now, she didn't come into the office for an ADHD evaluation, but with every physical and every assessment, we should be keeping our eyes open for these warning signs and catching them if we can. If we're worried about her behavior, we should send questionnaires home to all of these people: a teacher at school, a basketball coach, her parents, so that we can identify if there are issues in at least 2 settings. Another option we would have, in addition to these 3, is sending a questionnaire for her to complete. She may be old enough to understand the questions on the assessment, and it would be a great opportunity to include her in the decision-making process and the treatment plan for her behavior. It's important to remember that with every physical assessment that we do, that we are paying attention to the behavior of the child, that we're watching how they're talking to us, how they're interacting with their parents, and seeing to not only their physical signs and symptoms and well-being, but their mental and behavioral symptoms. And that's part of the duty of a family practitioner. All right, we're going to look at some quiz questions here. And remember that one of the objectives of this program is that you will be able to answer 5 quiz questions correctly. We will pose the questions and then discuss the answers. All right, question 1, true or false? Patients with a first-degree relative with ADHD are more likely to develop the condition themselves. I'll give you just a minute to think about this. All right, the answer to this question is true. Remember that we discussed children are 2 to 8 times more likely to develop ADHD if they have a first-degree relative with the condition. So it's important to ask if parents or siblings have been diagnosed with ADHD. Question 2, which of the following are symptoms of inattention? A child who does not seem to listen when being spoken to. B, an adolescent that does not follow obvious directions on a homework assignment. C, a child who is easily distracted by noises. Or D, a teenager that dislikes reading for long periods of time. E is all of the above. All right, if you got your answer here, the answer is E, all of the above. These are all symptoms of inattention. Question 3, how long do symptoms of ADHD have to be present in order for the DSM-5 criteria to be met? A, 1 month, B, at least 3 months, C, at least 6 months, or D, at least 1 year? All right, and the answer is C, at least 6 months. Question 4. Select all that apply about ADHD treatment. A. Individuals with ADHD can experience mental health recovery. B. Central nervous system stimulants are the most commonly prescribed class of ADHD medications. C. Currently there are medications that cure ADHD completely. D. Treating ADHD often requires the combination of medical, behavioral, and psychological intervention. E. Non-stimulant medications work by increasing levels of dopamine and norepinephrine and are the best choice for the treatment of kids with ADHD. And F. Although ADHD has been less thoroughly researched in adults than children, adults who have been correctly diagnosed with the disorder can still take advantage of the best treatment plan that best suits their needs. All right, the answer to this is A, B, D, and F. People who are on ADHD treatment can experience mental health recovery. Central nervous system stimulants are the most commonly prescribed class of ADHD medications. Treating ADHD often requires the combination of medical, behavioral, and psychological interventions. And although ADHD has been less thoroughly researched in adults than children, adults who have been correctly diagnosed with the disorder can still take advantage of an adequate treatment plan that suits their needs. And question 5. Select all that apply about current recommendations for the treatment of ADHD in children. A. Behavioral therapy and medication are good options for those 6 years and older. B. Behavioral therapy is recommended as the first line of treatment for children younger than 6 years. C. For preschool-aged children, that's 4 to 5 years of age, the primary care clinician should prescribe U.S. Food and Drug approved medications for ADHD as the first option. D. Antidepressant medications are approved for the treatment of ADHD in children younger than 6 years. And E. Parent training and behavior therapy has been shown to strengthen the relationship between the parent and child and to decrease child's negative or problem behaviors. The answer here is A, B, and E. Behavior therapy and medication are good options for those 6 years and older. Behavior therapy is recommended as the first line of treatment for children younger than 6 years. Most of the medications that can be used in children must be used in age 6 and older. Therefore, preschool-aged children should not be prescribed medications for ADHD as the first option. Parent training and behavior therapy has been shown to strengthen the relationship between the parent and child and to decrease children's negative or problem behaviors. These are the references used in our presentation. Thank you for listening, and we hope you've learned a little bit more about pediatric ADHD.